All right. Hello, everyone. Thank you for joining us for the Fall Patient and Family IBD Education webinar. My name is Arushi Malhotra, and I'm the Education Manager for the Crohn's and Colitis Foundation. We have a lot to cover in the next hour, and I want to make sure we have sufficient time to answer all your questions at the end of the presentation. So we're going to jump right in. Before I introduce our first speaker, I want to thank our sponsors. Without their support, this webinar would not have been possible. So if you could go to the next slide. I want to thank AbbVie and Janssen and Takeda and Gilead. So thank you all for making this webinar possible. So our first speaker is Dr. Phil Ginsburg, who joined Gastroenterology Center of Connecticut in 2005 and has a special interest in inflammatory bowel disease. He received enhanced training in this area as an IBD fellow at Johns Hopkins. He conducts research in the field of IBD and has authored numerous publications on the topic. Dr. Ginsburg serves as the medical director of research and director of the IBD Center of Connecticut. Dr. Ginsburg holds dual teaching appointments as an assistant clinical professor of medicine at both Yale and Quinnipiac Schools of Medicine. He's also the co-chair of our medical advisory committee of the Connecticut chapter. And without further ado, Dr. Ginsburg, I'm going to hand it over to you.
Thank you, Arushi. So, Alyssa, if you could just pull up you got it, perfect. So I'm going to dive right in because there's a lot to talk about with COVID and IBD. Just to begin with, we'll just discuss some basic definitions. So, coronaviruses are very common. And most of us know coronaviruses as viruses that cause the common cold. And typically in humans, they cause mild respiratory illness. So just, some background. I think it's important to kind of discuss the background so we understand sort of how we got to today's nomenclature. So many of you may remember back in 2003, there was something called SARS. SARS was an epidemic in Asia that began in China, and it stands for Severe Acute Respiratory Syndrome. And that was a new syndrome that was really scary. Initially, people thought this was going to be the next pandemic, like the Spanish flu, and it had a very high death rate. It had a very high kill rate, but fortunately, it was actually stopped and didn't make its way too much outside of Asia, primarily because although it had a high death rate, it was primarily transmitted in healthcare settings, and as soon as people figured out how to stop it in healthcare settings, it sort of fizzled. But for those of us that were around back then and remember, that was a really scary time. In the United States, we largely escaped that, but in Asia, many people have memories of the severe, really scary time, and so people began wearing masks, and so that's why you see in a lot of Asian cities throughout Asia, people wearing masks ever since 2003. And that syndrome really was a very severe acute lung injury that looked a lot like ARDS, which is in the medical field something that is basically a very severe pneumonia. So flash forward, and that, by the way, was caused by a novel coronavirus. So flash forward to 2013, when the MERS epidemic occurred. And MERS, if those of you that remember, stands for Middle Eastern Respiratory Syndrome. That also caused a SARS, a severe acute respiratory syndrome, but they didn't call it SARS, even though it looked the exact same. And so this is where we get to the sort of the nomenclature and the naming of these things. It looked a lot like SARS. It also was caused by a coronavirus. It also was very scary. And so this got the attention of the World Health Organization, many epidemiologists, and the CDC in the United States. But fortunately, that was limited primarily to the Middle East, and over 800 people were killed actually as a result of that until it was stopped. So there was this sort of growing recognition that something bad eventually was going to happen. And so when the first reports came out of Wuhan in China in December, it got everyone's attention. And I think I won't rehash the events that occurred in December and January, but this gets to the naming. So this also was a coronavirus. It also caused a severe acute respiratory syndrome. What do we call this? Do we call it the Wuhan or the China virus? Obviously, the World Health Organization didn't want to stigmatize this because this is something that affects the entire world. So the naming that was agreed upon by an international naming authority and the WHO is that the decision was made to call it Coronavirus Disease 2019 or COVID-19. That's where that name comes from. And it's one of many coronaviruses in a huge family of coronaviruses, and it's new. So the disease that we see is called COVID-19. And presumably this allows and by the way, they didn't want to call it SARS or anything related to SARS because we already had a SARS, and there was a lot of fear in Asia about naming it SARS, anything related to SARS, because of the events that took place in 2003. So the decision was made to call it COVID-19. Now, COVID-19 is the disease that we actually see that's caused by the SARS-CoV-2 virus. And it's CoV-2 instead of 1 because the original SARS-CoV was the virus, the severe acute respiratory syndrome coronavirus that caused SARS in 2003. So that's where SARS-CoV-2 and COVID-19 come from. When we order a test, the PCR, we're not ordering a COVID-19 test, we're ordering the SARS-CoV-2 test. That's the virus that causes COVID-19. So just to make sure we have our definitions straight. Next slide, please. Most common symptoms of COVID-19 are fever, shortness of breath, respiratory symptoms, cough, flu-like symptoms, okay? It's also important to recognize, because we are gastroenterologists and our patients with inflammatory bowel disease have GI symptoms, that COVID-19 can also have GI symptoms that look a lot like inflammatory bowel disease symptoms, and you can see them listed there, and there can be overlap, and this has been occasionally a source of confusion, and there have even been cases of isolated just GI symptoms alone in the absence of the other more common symptoms. So it's something that we have to have a low threshold to consider if there's new symptoms. Next slide, please. Okay, so what can we do to help prevent? Well, this by now is common knowledge. The most important two things that we can do is wash our hands, wash our hands, wash our hands, and use hand sanitizer. And number two, wear a mask. Don't just wear a mask if you're sick. Wear a mask all the time, every time you leave your house. And as you all know, Fauci has said, if all of us did those two things, then it's possible we could get this thing under control by the end of this year. The problem is that we all haven't been doing all of these things, but it's still nevertheless important for us to try to do. Social distancing is obviously important. It's been increasingly realized that the spread of COVID is primarily through respiratory droplets and aerosols rather than through fomites. But we are interested in trying to keep surfaces clean, and certainly if you touch surfaces with your hands when you're out and about, just try not to touch your face and wipe your eyes and that sort of thing. Next slide. Next slide, please. Okay, we're going to switch gears and just talk a little bit about medications. And this is another big part that I want to sort of focus on. Inflammatory bowel disease is an immune system disorder, right? So our most effective therapies are by definition immune modulating through different mechanisms of action, some of which are broadly immune suppressing and some of which are more targeted in their mechanisms of actions. Nevertheless, all of our most effective medications for treating inflammatory bowel disease are by definition designed to take a whacked out overactive immune system that's attacking you, our patients, and sort of knock it back down into line where it belongs, for lack of a better way of framing it. So there's the double-edged sword, right? So one of the reasons that we have our immune system is to identify and fight off infections. And so anytime there's an infection, that gets our attention if our patients are on immune modulating medications. Next slide. Okay, so this is a complicated slide, and I'll let you read through it while I talk about it. When this whole thing sort of really hit in March, April, and May, I literally, through telehealth and then later in person, every single conversation I had every single day, all day long, was, appropriately so, concerned patients saying, I'm really worried. I'm really worried about this COVID thing. And should I take Remicade, or I take Xeljanz, or any of these medications you see? Should I stop my medicine? Should I hold my medicine? Should I delay my treatment, or maybe skip an infusion or an injection of my Humira? And the answer is no, no, no. It was no then, and it's still no now. Why? Well, there's a lot that we don't know about COVID and IBD and COVID and immune modulating medications. But what we know for an absolute 100% fact is that when we hold or delay or stop important maintenance medications, that's when the disease, whether it's Crohn's or ulcerative colitis, relapses. And that is dependable, it's reliable, it almost always occurs in a majority of patients, because we don't cure inflammatory bowel disease with Entyvio or with Remicade or Humira. All we do is we stop it in its tracks, but it's very important to maintain with maintenance medications. This is a general principle of therapy. It's fundamental. Okay. So that's a fact. Now, there's no evidence. We have no data to support the idea that being on any of the medications that you see listed here will increase the risk of getting COVID. And in fact, there's a consensus statement, and it's widely believed. And you can link to this consensus statement down at the lower left. You see a hyperlink to the ioibd.org. This is an international working group of inflammatory bowel disease experts that have all pretty much agreed from the beginning, and they continue to agree, that being on IBD medications doesn't seem to increase the risk of developing COVID. And that has borne out as well in the limited data that we have so far. Now, it certainly is reasonable to ask the question, well, okay, if I get COVID, am I more likely to die if I'm on Remicade or Humira or any of these medicines? Or am I more likely to have a serious disease course or a complication? And the answer is, look, it's not an unreasonable thing to consider, and I completely understand the angst. But right now, the data that we have, and that sort of let me just back up and say that, that's a common assumption. It's a common assumption that we make, that because we're on an immune suppressing medicine, if we get a viral infection, it's going to become more severe. And so that's a common assumption, that if we get COVID, it's going to be worse. But that is an assumption. And actually, we don't work with assumptions. We like to have data. And the data that we have to date would suggest, and this is data that comes from a large multinational registry called the Secure Registry, that has now enrolled literally several thousands of patients, over 1,000 patients in the United States alone. These are patients with inflammatory bowel disease, just like you, who have been on medications just like this and who have developed COVID. And the experience seems to mirror that of the general population. There doesn't seem to be a signal that patients on Remicade or Stelara or any of these medications, I'm not going to pick on any, in particular, are associated with worse outcomes, with the exception of steroids, which we'll talk about in a second. So that common assumption that people make has not been proven in the large registry, at least, that we have, as well as the Wuhan and China experience, as well as spontaneous reporting and other case series. Now, we don't have controlled data. We won't have that kind of evidence, for several years to come. But so far, there doesn't appear to be a signal. And the last thing I'll say is that I myself have had several patients on these medications develop COVID, and, knock on wood, thankfully, it's been the same. We haven't seen any horrible outcomes, thankfully, and the experiences tended to mirror that of the general population. So, there's a lot that we don't know, but what we do know is, IBD is bad and being on medications is good. So please stay on your medications. Next slide. Okay, steroids. Steroids have no role for the maintenance of remission in inflammatory bowel disease. They're just a band-aid. They don't treat the underlying problem. They just cover up symptoms. And so for all of the above reasons, we hate steroids in general. So we really don't like for our patients to be on prednisone anyway. We do have data from the SARS epidemic back in 2003 that clearly showed that steroids such as systemic prednisone make SARS worse. So as a matter of routine, anyone that's on prednisone, we do try during this pandemic to try to get them off the prednisone. But of course, we try to do that anyway, okay? And obviously, don't do that on your own. Do that only in consultation with your physician. Next slide. The one caveat I'll say to that is that for those of you that are really sort of nerds in this area like me, you're probably aware that actually in selected patients, we're not talking about IBD patients, we're just talking about patients who get COVID. If it's moderate to severe COVID and they're in the hospital, oxygen requiring, right? These are checking a lot of boxes that don't necessarily apply. Then in certain patients, course of systemic steroids may reduce mortality by a marginal but statistically significant amount. So that is not what we're talking about here, okay? In general, we don't want our patients to be on prednisone, and prednisone is associated with worse outcomes in all comers, okay? The slide about children, it's kind of hard for me to speak to this because I'm an adult gastroenterologist, but let me just say that it's the same story. You see right there in the middle, stay on your medications and be smart. Follow all normal precautions and healthy practices. As many of you know and has been borne out, it seems that children tend to have a more benign, disease course with respect to COVID, that is, and we have very limited data in IBD specifically. Next slide, please. Okay, so in the 2 minutes, or maybe I have 5 minutes, I can't remember, that I have left, just some thoughts about what to do with respect to testing. So there's two sort of scenarios. One is where you test positive for the SARS-CoV-2 virus, and there are many different tests which are beyond the scope of this talk. But you don't actually have the disease, COVID-19. What are some examples of this? Well, we do COVID testing or SARS-CoV-2 tests for everybody before they come in for a colonoscopy or an endoscopy. And so it's possible you may be an asymptomatic patient who tests positive. That's just one example. If that happens, the first thing that you need to do is call your doctor. That's always going to be the right answer. And generally speaking, we're always going to try to lower any dose of steroids. And the rule is that if you're on an immune modulator, whether it be an oral agent or a biologic, we're going to hold dosing for usually a period of about 14 days and then restart, assuming no symptoms of COVID-19. Next slide, please. Well, what happens if you get COVID-19? Just like before, call your doctor, call your doctor, call your doctor. Your doctor is going to want to enter your information into the secure registry, which is de-identified, so no personally identifiable information is provided. Generally, there is a consensus that we want to continue medications like the 5-aminosalicylates and antibiotics and any topical rectal therapies. Probably oral budesonide is fine. None of those medications are immune suppressing, so they're probably fine to continue. However, we always want to try to taper off prednisone. We never go cold turkey on that, but we, will, under the direction of your doctor, try to taper that off if we can. And then immunomodulators, these are things like Imuran 6-MP, small molecules like Xeljanz, and the biologic medications. You can see all of them listed there, the common ones being Humira, Cimzia, Remicade, and Stelara and Entyvio. We're going to be fair to all of our biologics. Those are held during COVID-19. And I'm sorry, they're held when patients are having symptoms of COVID-19. And then the decision about when to resume them is going to be an individual decision that you'll make in consultation with your healthcare team. Next slide, please. Okay, so this is an old slide. I can tell you that I know a lot of the infusion centers throughout the state of Connecticut, and I can tell you that all the infusion centers are pretty much on board with this. we want to be really careful in our infusion centers. And you can be reassured as patients. I don't know of a single infusion center that isn't practicing sort of good practice. Everyone has a screening protocol to check for any symptoms of COVID-19. We call all of our patients the day before to make sure and go through a whole checklist to make sure that they don't have any symptoms. There obviously needs to be adequate spacing in the infusion unit with restricted visitation. So it's really just the patient that comes. There's enhanced cleaning protocols. And it goes without saying that everyone is masked. And I think that it's fair to say that all the infusion centers are pretty good about that. Home infusions is a special category for those of you that receive home infusions. That's not my preferred approach. It may seem at first sort of glance or at first thought, well, hey, home infusion's great idea, right? You don't have to go to an infusion center. Well, remember, this is someone who is going from place to place to place, other homes, that is now entering your home, which is your protected bubble. And so there is a risk there as well. So for that and a variety of reasons, I think that there's plus minus to home infusions in this setting, and we have not been advocating for that in my practice, although I'm sure that there's a lot of variability, throughout the state and the country. Next slide. So this slide is from April 1st when we were not doing elective procedures. The only thing I'm going to say about this is that we most certainly now are, flash forward 6 months later, definitely doing elective procedures. We do not want to withhold important elective procedures out of, sort of irrational concerns. And that's all I'll say. I'm glad, just because I have limited time, I'm glad to go further into this. But the bottom line is that, I understand that patients are concerned, and I know our endoscopy unit, and I can vouch for CTGI. I know that you, Sung, will say the same thing. I know that the hospitals, both all of the Greater Hartford healthcare hospitals and all of the Yale affiliated hospitals, as well as independent units throughout the state, have been rigorous and very very thoughtful about their protocols that have been put into place to protect both their staff as well as patients. And so we definitely do not want to withhold or delay important testing, especially with respect to restaging or surveillance for dysplasia. So please, if your doctor recommends a test or a procedure, you should go through with that. Next slide, please. So how can we take care of ourselves emotionally? Well, we're in a different place now than we were when this slide was created on April 1st. We now know that, yes, we need to be careful and practice social distancing and wear our masks, but we also don't want to be irrational and end up sort of isolating ourselves, because social isolation is a real problem. And so we want to pay attention to our emotional and mental health. You can see all of the things listed there to help with stress management and to try to unplug and use the support services that the Crohn's and Colitis Foundation have. And you can link to them through the ccf.org website. Next slide. Great. You can see that as well. Obviously, the children, we want to be supportive of them as well. Next slide. Okay, so the bottom line, and I've just got a few minutes left here, is that we want our essential workers who have IBD to feel comfortable working. Okay, so I appreciate that there is a lot of angst and concern, but I think I've already made my case for why we want to stay on medications and why we're not seeing any sort of obvious horrible signals either for getting COVID-19 or for complications of COVID-19 in our IBD patients. And as long as we're, practicing good hygiene, washing our hands, using alcohol rub, and practicing social distancing, wearing a mask, I am personally, and I know there's variability of thought on this, I'm personally not telling my IBD patients that they're not allowed to work just because they have IBD and they're on IBD medications. To what extent it's possible to work from home, great. But if you're an essential worker and you need to work, and just be smart about it. And I've had, ER providers, We've had providers who are, preschool or daycare providers, you name it, grocery store workers, bus drivers, etc. And knock on wood, as long as they're smart, we haven't seen, any horrible outcomes. Next slide. Oh, yeah. One point I would like to make, just going back to this idea of this, this sort of common assumption that being on immune suppressing medications is going to make COVID-19 worse. There are ongoing clinical trials right now that are actually looking at some of the medications that were listed on that slide intentionally being given to patients with COVID-19, right? So Xeljanz, for example, there's an ongoing clinical trial where Xeljanz is intentionally being given to patients with in the hospital at Yale in New Haven. And it's looking at Xeljanz as a potential treatment for COVID-19. Same thing with Humira. There actually is a Bill and Melinda Gates Foundation sponsored study in the UK right now that's just beginning, looking at Humira to be given actually in the community. And this is not IBD patients. These are just patients who develop COVID-19. And other medications have also been looked at, other biologic medications like IL-6 inhibitors, a long list of things that are beyond the scope of this discussion. Now, I'm certainly not suggesting, and I don't want anyone to take home, the suggestion that I'm saying that being on these medications that were listed on that previous slide somehow are going to help you if you get COVID-19, okay? But again, this common assumption that being on those medications is definitely going to be associated with worse outcomes, is an assumption. And there's a lot of science behind why these medications may be effective. The cytokine storm that occurs, which I'm glad to talk about offline with people if they want. But my only point here is that, be scared of of your inflammatory bowel disease relapsing, not so much the drugs. Obviously, we want to be smart, work with your healthcare provider, etc. Next slide. Okay, so learn more. You can link through the CCF website to educate yourself. I think that's great. Next slide. And I think that this is Yu-Sung's talk. So thank you. I think I went 2 minutes into your time, Yu-Sung. I'm sorry.
You're forgiven. Wonderful talk, though, Phil. All right. So let's switch gears a little bit. I'm going to talk about ulcerative colitis and advanced therapies. I'm going to be using trade names. This is not a CME program. I think it'll be easier to talk about drugs with the trade names as opposed to generics. And I'm going to focus mainly on ulcerative colitis. You can certainly spend another webinar talk on Crohn's disease and therapy for that. So when we talk about ulcerative colitis, we want to talk about what are our goals. And obviously, we want to diagnose patients early when they come in complaining of symptoms of ulcerative colitis, assess how severe the disease is, and then you want to get them feeling better and get them into remission with medications. Once they are on medications, you want them to be sustained on the therapy, maintained in remission, and prevent the relapse of the disease and keep the mucosa healed. And many times you do colonoscopy to look at that. Then we want to prevent complications of not just the disease, but also the drugs that we administer. So you want to be vaccinated. Obviously you want to be vaccinated against hepatitis B, get the flu shots, pneumovax, Shingrix for shingles, cancer prevention by doing colonoscopies to look for precancerous stages in patients with inflammatory bowel disease. And our goal is also to decrease the number of hospitalizations and hopefully surgeries too. There are some psychosocial aspects of these conditions that we many times don't have time to talk about in the office, but certainly are important. Things like depression, anxiety, sexual dysfunction. And then lastly, we want to talk about the cost of these medications, and hopefully we can make it cost effective, because that will improve the adherence and keep the patients on the drugs. Next slide. So in the old days, we used to talk about ulcerative colitis, staging it, mild, moderate, severe. As time has gone by, we've found that it's actually not very easy to decide on what's the best therapy based on that. So nowadays, we're looking more at the idea of what is the patient's risk for having surgery, basically colectomy for ulcerative colitis, when you take out the whole colon. That is the cure for ulcerative colitis. Without the colon, you can't have colitis, ulcerative colitis. So high-risk patients are the ones who have extensive disease throughout the whole colon, have very deep ulcers during colonoscopy. Younger patients, less than 40. Patients with high inflammatory markers, the C-reactive protein and the ESR. Patients that require steroids for their disease. Patients that require hospitalization. And then patients that get co-infected with things like C. diff and CMV. Low-risk patients would be more patients with more limited disease, maybe not the entire colon, maybe just the rectum or left side of the colon. And then it's certainly disease that looks more mild on endoscopy. Next slide. So now we talk about the newer therapies. So, Phil had talked about things like mesalamine products and steroids and immunomodulators. Now this is sort of the next step. So now we're talking about biologic agents, newer biologics, small molecules. Going back in 2005, Remicade came out for inflammatory bowel disease, in particular ulcerative colitis. 2012, Humira came out. In 2013, Simponi. 2014, Entyvio. 2018, Xeljanz. And most recently, 2019, Stelara. Next slide. So I'll go into each of these compounds and talk about efficacy. I won't go into exact details on the slides, but if you look at the bottom, you can see Remicade, Humira, Simponi, both in terms of clinical response and also clinical remission. And in the blue bars, they're all clinically significant. They're better than placebo when it comes to these responses. Next slide. Now, what are the challenges of the anti-TNFs? They are great drugs when they work, but unfortunately, in about roughly a third of the patients, they may not respond to the induction therapy, in which case they basically are not going to respond if you continue giving it to them. So no point in continuing maintenance therapy. And then roughly about half patients over time may actually lose response. And why does this happen? Well, it's felt to be due to these neutralizing anti-drug antibodies that form in the body due to these anti-TNF nature, and then sometimes low levels of these drugs. And then certainly sometimes your immune pathways that are driving inflammation may change a little bit. Putting these drugs on into your system may actually also change the pathway so that now there's another pathway that makes the inflammation go on, and you may have to switch gears. Next slide. Safety considerations. Certainly with TNFs, and you've seen the commercials on TV, one thing you always want to make sure is prevent infections. So one of the things we always check for, and these were one of the questions I was asked, is what do you look for before starting anti-TNF? You check for tuberculosis and hepatitis B status, and make sure those are negative. Usually with hepatitis B, you do it once, and then if they're not immune, we immunize them. Tuberculosis, we tend to check on a yearly basis. Demyelinating disease, which is like multiple sclerosis, we should avoid anti-TNFs in that class. Patients with advanced heart failure, bad heart disease, congestive heart failure in particular, advanced stages should avoid it. And there is a small increased risk, and if you look at numbers, it is quite low, 1 in 1,000 to 2,500 of things like lymphoma and skin cancer. Next slide. So there is black box warnings for anti-TNFs. You want to watch out for serious infections that can lead to hospitalization and potentially death of things like tuberculosis, hepatitis B, bacterial infections, fungi, unusual infections, malignancy, lymphoma, other things can occur in both adults and children. I'm going to answer a couple of the questions that came on through the initial answer Q&A submissions. One of the questions is, what is a biologic? Well, biologic basically is a therapy that's derived from living organisms that can modify the immune system response. These antibodies stop the certain proteins in the body from causing inflammation that Phil alluded to in his talk, and that's the cause of inflammatory bowel disease and its complications such as scarring, stricturing, and cancer. The different anti-TNFs, one of the questions was, how soon do you see improvement with things like starting Remicade, say. It varies. I would say in generally, I would see a noticeable response roughly 2 to 3 weeks after starting therapy. Some agents, in particular Xeljanz, has had some very interesting, very fast response rates, as fast as 3 days in terms of clinical improvement. Next slide. So we'll go on to the new biologics, not the anti-TNFs. Next slide. So Entyvio was shown to be efficacious in ulcerative colitis, once again the green bar, compared to blue placebo in early on in week 6, and then clinical remission at week 52. And if you see on the green and then the orange bars, the normal dosing is Entyvio intravenously every 8 weeks. There are some times when you have to lower it down to every 4 weeks in patients that may lose response or not quite have enough of a response. Next one. I have to admit, Entyvio does seem to have a very good safety profile. There does not seem to be an increased risk of serious infections. In fact, there's no black box warning for infections or malignancy. No cases of PML, which is a rare but often fatal neurological condition that has occurred in some of the sister drugs of Entyvio that came out early on. Very few infusion reactions. I've sometimes seen some rashes occur, but they tend to be self-limited. So fairly good safety profile for Entyvio. And just to give you a quick on how it's given, it's intravenous right now. There's talks about a subcutaneous version, sub-Q, self-injectable form that may be coming out within the next few months, possibly. Remicade is intravenous infusion. Humira is self-injectable, and Simponi is self-injectable too. Next one. Stelara has also been shown to be efficacious in ulcerative colitis. Once again, you'll see in the bars, the green and orange compared to placebo in blue. The initial dose is intravenous, followed 2 months later by subcutaneous dose. And we usually do give it every 8 weeks. On occasion, we try to get approval sometimes for every 4 weeks dosing if the patients once again start having loss of response. Next slide. It also has a fairly good safety profile too. Very low risk of opportunistic infections from cancers. Maybe a slight uptick in cardiovascular events, but it seems like it was more psoriatic arthritis patients and not IBD patients. It also does not have a black box warning for infections and malignancy. Next slide. Xeljanz, I have to admit, there was a lot of talk about Xeljanz and hopes that this would be a very effective and safe drug because it's the first oral agent in terms of advanced therapy for ulcerative colitis. It's not an anti-TNF. It's not a biologic. It's actually something called a small molecule. So it's actually very short-lasting, quick-acting, but short-lasting. If you take a dose of it and stop for 24 hours, the next day essentially is almost out of your system. So initially it seemed very exciting that this drug had been FDA approved for ulcerative colitis, and once again you see the efficacy. Usually it's given as 10 milligrams twice a day in the blue bars, and then in the remission stage, anywhere from 5 to 10 milligrams twice a day is shown to be efficacious. Next slide. And then unfortunately some kind of red flags came out with Xeljanz. Infections seem to be a slightly higher rate, in particular viral infections such as herpes zoster, shingles. And it seems to be dose dependent. It seems to be occurring more with the 10 milligram dose as opposed to the 5 milligram dose. And we certainly do recommend our patients, if at all possible, to try to get the shingles vaccine before starting Xeljanz. I wouldn't necessarily stop it if they needed it, and I would give it to them, but recommend that they get the shingles as soon as possible. And also there was very odd situations of cardiovascular events, things like clots, deep vein thrombosis, and then pulmonary embolus occurring mainly in the rheumatoid arthritis population in the higher dosing of Xeljanz, 10 milligrams twice a day. So that unfortunately did result in the black box warning for infections, malignancy, and thrombosis, which is clotting. And also the FDA even then came back afterwards and said you should only really use Xeljanz if you failed another advanced therapy, such as an anti-TNF or potentially the newer biologic like Entyvio. So that's sort of dampened our use of Xeljanz, unfortunately. So we seem to be reserving it more for as a backup of patients that have failed the other therapies. The head-to-head trials aren't that many. The only one that really stands out is the Entyvio versus Humira study for ulcerative colitis. It does seem like Entyvio does win out slightly. They're not huge numbers, but they are statistically significant in terms of endpoints of clinical remission and endoscopic improvement when you repeat the colonoscopy on these patients, looking at the Entyvio bar in the orange as opposed to the Humira bar in the blue. Of interest, though, being free of steroids, though, was no different between the two. Next slide. There are ongoing trials looking head-to-head for different biologic agents, and hopefully we'll see the results of these within the next year or two. Next slide. So when you kind of look at real-world data and bring it into clinical practice, what are the takeaways? Well, anti-TNFs have had a long track record. We've seen that it's been around since 2005 and has been very efficacious and safe in ulcerative colitis. Entyvio seems slightly superior to Humira for moderate to severe UC. Does have a good safety profile, as does Stelara, also has a very good safety profile. And as I mentioned before, Xeljanz has an excellent safety profile, even in patients that have failed an anti-TNF. However, safety issues need to be continued to be monitored. Next slide. So what are the role of biologics in UC? Next slide. So anti-TNFs, when you kind of weigh the pros and cons, we know that they are effective in inducing remission and decreases rates of colectomy surgery. They are more immunosuppressive, and there is greater risk of systemic infection and slightly increased risk of malignancies. Next slide. The small molecules and the newer biologics, well, we talked about Xeljanz are effective. In fact, all of these are effective in both patients that have been experienced to anti-TNF, exposed to anti-TNF, or naive patients have never seen an anti-TNF. Xeljanz seems to work very quickly, seems to be well tolerated, and is oral. However, we have seen this concern about increased clotting, so we are still sort of keeping an eye on Xeljanz and maybe using it as a backup medication. Stelara has a very good safety profile, maybe some cardiac events in more psoriatic arthritis patients, but does seem to be effective in naive and experienced anti-TNF patients. And the same as Entyvio. It is gut selective, so that's the one thing that seems to be attractive to a lot of patients who are worried about more systemic side effects of these biologic agents. It seems to be very geared to the gut, low immunogenicity. And its downside, of course, it's intravenous for now. So you need to come to an infusion center to get them infused. Next one. So when kind of looking at the whole picture, my approach is if the patient's in the hospital, very sick, that does seem to support using Remicade in those patients. Moderate to severe ulcerative colitis, you can use Entyvio, you can use the other anti-TNFs, Humira, Symphony, or Stelara. Safety profile, as I mentioned, Vito and Entyvio does seem to have a very nice safety profile, followed by Stelara. The anti-TNF agents and Xeljanz have similar safety profiles. And then, lastly, we have to look at the special situation. Older patients with inflammatory bowel disease who may have heart disease, you may want to steer away from anti-TNF therapies. Slightly higher risk of cancers if they're on other agents too. Younger patients, on the flip side, women of childbearing age, you may want to kind of be careful of which agent you use. Some are found not to be fairly safe in pregnancy. Xeljanz is recommended we not continue during pregnancy. And then lastly, the comorbidities, patients who've had clots before, obviously you want to be careful of which agent you pick. Patients who've had potentially a family history of multiple sclerosis, or interesting, if you have patients with joint pains, you may want to have agents that actually have more systemic effects as opposed to gut specificity like Entyvio. That is the last slide. Yes, thank you.
Thank you, Dr. Sang. That was very informative. Just a reminder for everyone, you can submit your questions to the chat box. I don't see many here just yet, but I'll give it a few minutes so you can type your questions in. Dr. Ginsburg, if you could come back as well, again, just in case we get any questions. I guess I actually do see one question here. This person's asking about their daughter, who's a young adult and is living with UC, and has been on Entyvio for 20 months, and they're wondering if there's a connection between hair loss and Entyvio.
I mean, I've seen anecdotally some patients have hair loss with the different agents, and then I've seen it across all agents. So I try to tell the patients if they can talk to a dermatologist to see what they can do in terms of using some agents to help minimize their hair loss. But certainly, I think hair loss is actually potentially a side effect of all of the biologic agents you see in the package insert.
And then there's a question about how long does it take for Remicade to see an improvement?
As I mentioned, I typically will see my general experience is roughly a week after the second infusion. That's when a lot of my patients will start feeling a noticeable difference, and they can tell me clear cut the number of bowel movements have decreased, the bleeding has decreased, the pain has decreased. Of course, it ranges. I've had patients that leave the infusion centers feeling better. Obviously, that's a placebo effect. And then others may take a little bit longer. But in general, I think most of us agree that you try to give these agents, 4 to 6 weeks to really take effect before, quote unquote, giving up on them.
And I guess this is someone else asking the question, but are there any negative effects if you've been on Remicade for over 10 years?
I believe so. I mean, I think as long as you're having continued monitoring by your gastroenterologist, who's infusing the agent, and they're checking labs and doing routine screenings, I think the long-term risks of being on these agents are greatly outweighed by the potential disease flaring being off the agents. And of course, I was assuming that you don't develop things like congestive heart failure or develop a cancer of some sort. That changes everything.
And if they've taken, it's a very specific question, but if they've taken about 6 treatments of Remicade, do you think, and it hasn't shown any effect, they should consider another biologic?
Yeah, I mean, the gastroenterologist that's prescribing it really has to decide at that point, is it truly, quote unquote, not working? And, many times we'll do different ways of testing to see if it is not working. Some people will be less invasive and do blood work and stool testing, checking the calprotectin levels. Others will actually do a scope, whether it's a FLEX-SIG or a colonoscopy, to look in there to sort of prove that the drug is not working. And certainly we want to do things like checking levels of Remicade and check for antibodies. So certainly I think the gastroenterologist prescribing the Remicade needs to look at the whole picture and decide best if it's not working, why it's not working.
Dr. Ginsburg, this one's for you, and this is someone who missed some of the beginning of our webinar. So without having you do your entire presentation again, are there any quick takeaways that you have for this person, so that are specifically, as a patient and related to COVID, that they should keep in mind?
So that was a pretty broad question. You're asking, are there any sort of key points from the talk? Yeah, I would
Yeah.
just emphasize, um, anytime we make a decision about whether to continue medications, we have to weigh the risks and the benefits of those medications against the risks and benefits of disease, relapse. And that has to be taken in the context of the risks of COVID. So, in general, what we're saying and what I think I made clear from the talk is that, we really want our patients to stay on their medications as a top priority, but to do so in close consultation with their physicians. And obviously, if they get COVID, they need to call their doctors right away. And then that discussion will be had and it'll be individualized.
Thank you. That's very helpful. And this is more for Dr. Sang, but I think you both can take a stab at this. But what is the role of diet in UC? Or is there any?
So we could have a whole hour long sort of talk just about that. We're asking about ulcerative colitis specifically.
Yes.
Yeah. So in ulcerative colitis, there's never been any single dietary treatment that has ever been consistently shown in controlled studies to induce, and certainly not to maintain, remission. And so it gets back to sort of what I said at the in my talk, in my part of the talk, which is that ulcerative colitis and Crohn's disease are immune system disorders, and it is true that there are certain environmental factors that can make diseases sort of exacerbate or trigger flares, but at the end of the day, we don't really sort of treat the disease, if you will, with dietary therapies as a sole sort of treatment. That said, and again, I'm talking about ulcerative colitis specifically because in Crohn's it may be a little bit different. Um, in people that have active disease, we don't want to ask an inflamed colon to do work. So it's sort of like the analogy that I use with patients. It's kind of like pouring salt on a wound. You put salt on a wound, it's going to hurt, right? But it's not necessarily going to make the wound better or worse. It's sort of similar to, ulcerative colitis. If you eat something that is asking an inflamed colon to do work, it's going to hurt. It's not going to make the colitis worse or better, but it may exacerbate symptoms. So oftentimes our patients will say, well, I eat certain foods and it triggers flares. But what's really happening is that certain foods are exacerbating symptoms. It's not necessarily making the disease worse or better. So I tell people with active disease, low residue, lactose-free diet. We get the disease in control with medical therapy. Once the disease is in a complete clinical, endoscopic, and ideally even microscopic or histologic remission, what we call a deep remission with normalization of biomarkers. And once all of those boxes are checked, then you're just like everybody else. You can eat what you want. So I don't have any particular dietary recommendation for patients who are in remission with medical therapy.
Anything to add, Dr. Sang?
No, I agree with Phil. Certainly with ulcerative colitis, I think, it's the old dictum, doctor hurts when I do this, well, stop doing that, So the patients will learn what aggravates their disease when it's active. And certainly a low residue lactose-free diet makes total sense.
Great. I don't see any other questions in the chat box. Just kidding. Yet. And this one's for you, Dr. Sang. What upcoming medications that are not quite yet available show promise? So I guess they're asking about medications in the pipeline.
Actually, they were coming up in that slide that I had with the head-to-head trials. There are some coming out, probably more so, probably within year and a half, maybe. Filgotinib, probably the next one that will come out. It's an oral agent, Gilead drug that probably will work for both Crohn's and ulcerative colitis. So That seems possibly the next new agent to come out for IBD. But I think in the next couple of years, a few new ones hopefully will reach market.
Great. That's pretty much it in the chat box. I'll just give it one more minute in case someone wants to squeeze in another question. Just for everyone who did join today, we did record this session, so we will make sure to send over the recording tomorrow to everyone who joined. So in case you missed some of the presentation, you can watch the recording. And I see thank yous pouring in, and I am just going to echo that. Again, thank you so much, Dr. Singh and Dr. Ginsburg. I think this has been such a unique and challenging time for everyone, especially IBD patients. So it's just very helpful for them to be able to get all this information from the comfort of their homes. So thank you both. And Alyssa, thank you for running our slide deck. And thank you everyone for joining us, and thank you to our sponsor for making this possible. Have a good night. Thank you.
Bye, everybody.
Bye.